And I have some disclosures because we're giving talks with the support of some pharmaceutical companies as well. And the Onconet Nord, the label you will see on the left-hand side there, is also a community of breast cancer specialists. It's not only gynecologists as it used to be in Germany, it's also medical oncologists, surgeons, radiologists, mammographers like Sergey is. So it's an interdisciplinary group which is interested in treating breast cancer. And I think this is important to bring all these different people together to have the best solutions for the patients. So I brought three topics. The first topic is early breast cancer because there are a lot of questions, and in Germany we might do it a little bit different, especially the handling with endocrine therapy. And I'll tell you something about that. And then we have a lot of changes in the treatment of triple negative breast cancer, and also in the early as well as in the late situation of triple negative breast cancer. So let's get started. I can recommend to you, we have some guidelines in Germany, and the guidelines are from the AGO. It's also a community of people who gather after each big congress what is changing, and then they make recommendations. And now for the first time, we have the recommendation that we use some kind of pre-operative endocrine therapy, which is for patients where we don't have a clear indication for chemotherapy. So we divide the patients in hormone receptor positive, HER2 negative patients in three different groups. There's one group where you have clearly no indication for chemo because the tumor is less proliferative, it's small, and you don't have any nodal involvement. And you have, on the other side, patients with a clear indication for chemo, where you have a high proliferative hormone receptor positive tumor with a lot of tumor load or tumor load in the axilla. But then the most patients, you have something in between where you don't really know, is this a patient for chemo or not? And you probably know that we use these gene expression profiles like Oncotype or MammaPrint, for example, to have an answer if it's a high risk or a rather a low risk tumor. And in addition to that, in Germany, we use a preoperative endocrine treatment for 2 to 4 weeks, which is some kind of an endocrine challenge. And with these two informations together, the result of the gene expression profile and the preoperative endocrine treatment result, after the operation, we know if the patient is suitable for breast cancer, for chemotherapy or not. And this goes all back to our ADAPT trial. It's an umbrella trial where these patients get endocrine induction therapy. We call it also endocrine challenge for 3 weeks. And if you then have a patient which is with highly nodal involvement, you go for chemo, for example, for this kind of chemo, but doesn't matter. Use your own standards. If you then have a patient who has 1, 2, 3 positive nodes or is node negative, and you have the recurrence score result from an oncotype, which is between 12 and 25, then you use the endocrine response information after surgery. You do the surgery or another biopsy, and you see after 2 to 4 weeks of treatment with an endocrine treatment, if the Ki-67 level goes down below 10%, you can, most of all, quit chemo, because then you have a low-risk tumor. I will show you in a minute the result of the trial. If you still have a Ki-67 above 10%, you probably should go for rather a chemotherapy in this kind of patient. So I show you here, we have the two groups, the premenopausal patients below 50 years of age or the elderly patients. And you see, if you have endocrine responders with a recurrence score between 12 and 25, they have literally the same distant disease-free survival than patients with a very low recurrence score. And this is the same with the group which is older than 50. Although we have here in this group also patients with 1, to 3 positive lymph nodes. So I think the addition of endocrine challenge to the information of the recurrence score is a very good step forward to make the decision for the patient if you really need chemo or not. And if you want to use endocrine treatment, you rather use something very potent. Here, my slide got a little bit confused, but you see here, if you have an endocrine response, you should rather use a combination of, in premenopausal patients, of an aromatase inhibitor with ovarian suppression. Because in this group of patients, the premenopausal patients, the ovarian suppression is also very effective in combination with an aromatase inhibitor to decrease the proliferation of the tumor. So if you want to do an endocrine challenge in a premenopausal woman, use this combination, not tamoxifen by itself, because the endocrine response with tamoxifen by itself is not as good as with the combination. Here you see it again, the combination of ovarian suppression together with an aromatase inhibitor, it's better in the combination than with tamoxifen by itself, or the tamoxifen by itself situation. So even the combination of tamoxifen with ovarian suppression is not as good as the combination of aromatase inhibitor plus ovarian suppression. So always use this combination in orange to have the highest benefit of this kind of treatment. Another issue I want to share with you is the intensification, or to intensify the endocrine therapy after you've done your operation and you decide this patient needs 5 years of endocrine therapy. We have new information that the addition of CDK4/6 inhibitors such as abemaciclib is beneficial for these patients. There has been a trial, the MONARCH trial I show you, which delivered the results that with high-risk patients with nodal involvement, 4 or more lymph nodes, it's better to have not only endocrine therapy by itself, but also add for 2 years abemaciclib, which is a CDK4/6 inhibitor, to prevent this situation here. The most recurrences we have in the first 3 years, but we also have more than 50% of the recurrences with over a time period of another 15 years. And you see this in this graph. So to prevent late recurrences, it's better to have a very good and tailored endocrine therapy, and also in a high-risk situation, add this treatment like we did in this MONARCH-E trial, where we took place in Germany in this trial as well. We added abemaciclib to endocrine therapy for 2 years of the 5-year endocrine therapy treatment period with this kind of risk factors. You either have 4 or more positive lymph nodes, or you have 1 to 3 positive lymph nodes and a grade 3 tumor, or a tumor which is larger than 5 centimeters. And with this, you see these results over time. This is the IDFS. So the recurrent free time, you see that there is a, I don't know why it's jumping though automatically. Let me do this back. You see this different in IDFS benefit over time, which is still increasing. So it's more than a 32.5% reduction in risk of developing distant metastases. So therefore, in this high-risk cases, we use this drug. Although this drug comes with side effects, and just quickly let me mention the most side effects which will occur is diarrhea. But as you can see here, grade 3 diarrhea is very rare. And every patient gets a prescription with loperamide on this the same situation. And when they use loperamide, they will hardly have any kind of problems with diarrhea in this situation. The patients use it by themselves. If they seem the diarrhea is coming up, they will sort of titrate it with this drug, and it shouldn't be a problem. Fatigue might be a problem, so that these patients are not as capable as they used to be with endocrine therapy by itself. But that's mostly it. We don't have many neutropenias in comparison to other CDK4/6 inhibitors like ribociclib or palbociclib in this situation. But right now, only abemaciclib has an approval in Germany to be used in this clinical situation. But there will be another drug in the first quarter of 25. It will be approved by the European Council, which is ribociclib. They did a similar trial for patients, but they took also node-negative patients with some kind higher risk. You see, it's either the risk, which is a Ki-67 greater than 20%, or an oncotype recurrence score, which is higher, or other genomic profiling and a grade 3, or you have a node 1 patient with 1 to 3 positive lymph nodes, which has an anatomical stage 2B or 3. So it's a bigger number of patients treated. It's like more than 5,000 patients treated in this situation. And you see here the results. You also have a decrease in the hazard ratio for these patients treated with ribociclib. But the difference is the treatment time here is longer than the treatment time with abemaciclib. It's 3 years instead of 2 years. And the side effects are a little bit different from abemaciclib. But we have also all subgroups of patients who will benefit for taking this drug. And that's why we will have this approval ready in the first quarter of 2025 to take this drug. Here you have a decision or discrimination between the different anatomical stages. And although you have low stages, you will still see a difference in the IDFS, which is significant. And also by nodal status and the node-negative patients with this kind of defined criteria, you will have a difference in IDFS, which seems small, 2.6%, but it's clinically significant, and it's still a reduction of more than 25% in risk. So therefore, the approval will be there. Until we get the approval, we have this trial going on in our clinic, which goes in Germany and I think in Switzerland and Austria as well. It's called the ADAPT-Late trial. It's the same group of patients like in the NATALEE trial, more or less, but with abemaciclib, which is already approved for patients with high risk, 4 or more positive lymph nodes, as you've learned. But we can use right now for these patients until we're waiting for the official approval of ribociclib, abemaciclib in this trial for our patients. And we have like in our center already more than 70 patients recruited for this treatment. So I think it's a very effective way to decrease late recurrences, to have an optimal endocrine therapy, and also tailor the endocrine therapy if you have a little bit of a higher risk with the addition of a CDK4/6 inhibitor.
So this is Christian. I have maybe some questions.
Yes.
On this first part. So about the NATALEE study, you said that there are some side effects on the treatment. And what is the difference between abemaciclib and ribociclib? They are quite similar, or you would say they are different. So
No, I think they're different in concerns of side effects. In abemaciclib, it's mostly GI side effects, so diarrhea and a little bit of nausea, deaptance, something like that. The hematological side effects are less common, like neutropenia, for example. Whereas in ribociclib, you have more neutropenia, you have liver tox, so the liver enzymes will increase, and so you have to watch this. And also to start ribociclib, you have to do an ECG because the CQT time, which might be important for this because it can be prolonged by ribociclib. Therefore, you have to watch the heart in the beginning, although it's not a real big issue to do an ECG in advance. And if the QT time is normal, everything is fine, and you can take the drug. But there are differences.
Is it possible to change this medication during the therapy if you see there are some side effects, is very hard for the patient, or is not indicated?
So right now we don't know because we don't have the approval for ribociclib yet, so we don't do the switching, but we know the situation from the metastatic situation. In metastatic breast cancer, we use CDK4/6 inhibitors for quite a while right now. And yes, we do. Sometimes we have good responses to ribociclib and have an increase in liver enzymes. Mostly, this will resolve after leaving out the liver enzymes. The drug for 1 or 2 weeks and then start with a lower dosage, for example. But if you don't see any kind of improvement, you can also change the drug. And to have this opportunity of having 2 or 3 drugs available for the patient is very useful for us as the doctors treating the patients.
Yeah, I have one more question to Monarch E study. They have some subgroup of patients who did ctDNA in the blood. Do you have some comments on this? So is still reliable for predict the recurrence? And if we have this data, so what we can do maybe in future?
Yeah, sorry. Some kind of telephone is ringing here. Hang on a sec. Hallo? Ja. Ja, ich bringe das Telefon nachher runter, ja? Ich bin gerade im Vortrag. Ich bringe es nachher runter. Danke, ciao. Yeah, so there is a test called Garden test, which is introduced now very broadly. At ASCO, they had a big booth there to show this kind of test. I can share the website with you if you're interested. Do you see the website here? Gardent. This is the test, and they do different tests. They have a test for circulating tumor DNA. They do tests for PD-L1 testing. But for minimal residual disease is it's called the Garden 360. And we use it only in a combination with clinical trials right now, because it hasn't been shown in a randomized trial that this test will be beneficial to the outcome of the patients. We have some very early clinical data that these kind of tests might be good to influence the treatment very early. For example, the test is already positive, you have an increase in circulating tumor DNA, but you don't have any kind of signs in the clinical evaluation. Like you don't see any tumors in the scans, PET scan or CTs or whatever. But on the basis of the circulating tumor DNA, to make a decision to change treatment already. And there are some clinical data suggesting that this might be beneficial for the patient. But it's not a big trial. It's not been randomized. So I think we have to wait. And we do a trial right now here. It's called the CAPTOR trial. it's for metastatic patients, not early breast cancer. It's metastatic patients. They get ribociclib. And at the same time, we measure ctDNA with this test. And afterwards, once the patient will progress into another situation of treatment, we will be able to see if the ctDNA levels were earlier responding than our clinical tools available right now. And probably this trial will help to introduce this kind of testing in our clinical routine. But right now, I wouldn't suggest doing it like this, because nobody really knows in the world if it's a wise decision to change the therapy only on the basis of an increased ctDNA result.
Great. Can you share the link with us, because we didn't get it?
Do you see it here?
No.
Okay.
We see your agenda now.
Now you see it, right?
Yes. Guardant 300.
Guardant 360.
Mhm.
And the company is called Guardant. Did you see here the website guardanthealth.com? And yes, you can send it. There are special tubes. You can send it to a central lab. Right now, it's only in the US, so it has to be shipped by plane. And then you'll get the result via email and have an information. And in certain situations, it might be helpful. So and patients starting asking about it, but it's nothing for the routine use right now.
I see. And we have one more question from Alexander Berzoy in the chat, or it's not a question, it's a comment. First or 2 months after ovarian suppression, initiation AI not indicated, only TAM. AI added only after menstruation stops, appearance of hot flushes, and so on.
Okay, now usually what we did in the earlier days, we did the injection of the ovarian suppression, and it takes a few days until it really is reliable working. So in a delay from 1 week, we started then the aromatase inhibitor. But there are trials already that it's not dangerous to start the aromatase inhibitor straight away. In, for example, in IVF, to do a stimulation of the ovaries, you do treatment with letrozole or anastrozole by itself. It will increase the level of oocytes producing or generating. But I think you don't have to be afraid, because the GnRH injection will work very quickly. And to make it more easier for the patients, we give them both drugs at the same time they start taking the drug, and we don't have any kind of negative effects from this. It was allowed in the ADAPT trial to do it like this at the same time. If
Perfect.
that was the question. Although you're obvious, it has strong side effects. The stronger the endocrine therapy is, the stronger we have the side effects with hot flushes. But we have now another drug approved to treat hot flushes. And there's also the possibility to use venlafaxine, for example, which is a serotonin reuptake inhibitor. It's usually an antidepressant to get rid of hot flushes.
Great. Thank you so much.
So if you want, I can sort of go a little bit further. Do you see the slides right now? Yes, right?
Yeah, we see agenda. Yeah. Yeah.
So we can move on to triple negative, early triple negative breast cancer. And I think it's another very important field, because the therapy of early triple negative breast cancer changed quite a bit over the last few years. We have the introduction of pembrolizumab, which is an immune therapy, so-called. So an ICI, immune checkpoint inhibitor, which is added to the classical chemotherapy, which is now established as a combination of an anthracycline containing therapy like epirubicin and cyclophosphamide, and paclitaxel and carboplatin. We have been talking about carboplatin for a long time in the last years, 10 years at least. And we always said, well, is it beneficial to add platinum in triple negative breast cancers? And I think we have so many trials right now supporting that the use of platinum is beneficial in triple negative breast cancer to obtain a pathological complete response. And the pathological complete response after neoadjuvant chemo is always connected to a better outcome in triple negative breast cancer. So you see here in younger patients, the platinum use is even more evident than in older patients. So it might be the younger patient who benefit more. And even in the overall, in the event-free survival, it's also the younger patients who benefit from the introduction of platinum in triple negative cases even more. But in the meta-analysis, which was just recently published in Breast, we see all these trials together. And if you add the trials up, there's also a benefit for the addition of platinum in the neoadjuvant setting. And you see here, it all favors platinum in the end, regardless of the age of the patients. And you see the subgroup analysis as well, with only a very few very potent trials. It always favors the use of platinum in the neoadjuvant treatment for triple negative breast cancer. And then after this kind of treatment schedule was established, we have the introduction of pembrolizumab, and pembrolizumab added to this chemo even increased the effectiveness. And you see, especially in the patients who don't reach PCR in the EFS or IDFS, we have a benefit for the patients, which is really substantial. And we can only speculate why this immune checkpoint inhibitors are working so well together with chemotherapy, but it might be not any chemo. It is the effect of the doxorubicin or epirubicin, which is some kind of an upregulation of the immune regulated genes, and therefore the immune checkpoint inhibitor is working even better if you have this combination of epirubicin or doxorubicin with an ICI. And therefore, we have it in our recommendations that we use pembrolizumab in the clinical trial, the Keynote trial I've just shown you. It is only used in tumors which are bigger in size than 2 centimeters. So we only have this kind of approval in this situation. If you have a smaller triple negative early breast cancer, you only use the standard chemo or even decrease the chemo to taxane and carboplatin, for example. And if you have afterwards some kind of a remnant tumor, so you do the chemo, you do the operation, and you still find vital tumor cells in the tissue, you can do a post-neoadjuvant treatment. In the regular basis, you complete pembrolizumab for 1 year, but you can also switch the compound to either capecitabine, or if you have a patient with a BRCA mutation, you use olaparib. So I think this is also a situation where we are able to tailor our treatments very well right now with these kind of drugs. So I think it's a very, very much improved situation compared to 3 years back when we didn't have the ICIs and we didn't have such a high number of patients reaching pathological complete response. And we have some kind of overall survival benefit reported by the press from pembrolizumab. And I think we are eager to see the results on the ESMO meeting just in a few weeks. And I think it's not only the improvement of IDFS, it's also an improvement of overall survival using ICIs.
I have here, this is, it was a second part, yeah?
Yes, yes, yes.
I have some question about this genetic mutation. So you said that if you have genetic mutation, this can change the therapy. And when you will make this analysis for the mutation, you have some important
Criteria?
criteria, yeah, for this test?
Yeah. Yes, that's true. We have so you have to make a judgment if it's likely to have a BRCA1 or 2 mutation, or if it's not likely, because obviously this kind of genetic testing is very costly. So in the so-called consortium, we have a list of facts we put together. And if you gather a certain amount of points, you qualify for testing. So for example, in triple negative breast cancer nowadays, every woman below 60 has a right of testing in Germany. If you have a hormone receptor positive tumor, you have to have a little more people also having breast cancer in your family. And the younger they were, the more points you gather for the testing. So for example, if you have a sister which has a breast cancer below 50 or even around 30, and you have the breast cancer in any kind of age, this is more than 10% likelihood that you have a mutation. So then you can go straight for mutation. And then straight for testing. And then this testing will be paid by the insurance companies. So these are criterias, which is family history, basically, and also tumor biology.
Great,
so
thank you
in
so much.
negative cancer, it's more likely to have a BRCA1 mutation than in hormone receptor positive. But within the group of hormone receptor positive breast cancers, we have about 4% who have a mutation. And in Germany, we have around 70,000 newly diagnosed breast cancer every year, and 4% is quite a number. So that's why we in our place, we always check the family history and search for family members who had breast cancer or ovarian cancer to make it possible to have a genetic testing done.
Great, thank you so much.
So somebody's raising the hand. I don't know if we want to take this question right now or if I should proceed to the end and we take the questions in the end.
Yeah, we will maybe let the colleague to ask. I just try to give the possibility. Yeah, please. So, Inga, you have some question? No, I think so. So we can go further. No question.
All right. But anyway, if she wants to type it or whatever, we take
Yeah, you can type it.
delay. Okay. So let's move on to the metastatic situation in triple negative breast cancer. I think it's a very interesting situation as well, because in this situation, we had the ICIs were introduced quite early, but we also have another group of drugs introduced recently, which are the ADCs, which is an antibody drug conjugate, as called here in the end. You see the antibody drug conjugates, which are introduced here after ICIs are not working anymore. But the first question you have to ask and you have to answer yourself in a triple negative metastasis cancer is if the cancer is PDL positive. Because in comparison to the early situation, triple negative breast cancer situation, you don't have to check for PDL expression, but in metastatic disease, you have to, because the trials have shown only in a PDL positive breast cancer, the immune checkpoint inhibitor works. And if you don't have a PD-L1 expression level, then you can't use the ICI. And you have different methods of checking for either pembrolizumab or atezolizumab, and your pathologist have to give you the information what kind of scoring system they use to make the decision which kind of drug you can use. So this is very important to know if you want to use either atezolizumab or pembrolizumab. But these are new drugs independent of any kind of testing, is sacituzumab govitecan and trastuzumab deruxtecan. These are two so-called ADCs, antibody-drug conjugates. And as we all know, these antibodies like trastuzumab from older days, now these antibodies are pimped. They have side chains with drugs, and they get introduced into the cell, and in the cell the side chain will be cleaved by some enzymes and the drug will be released, and so the drug is very potent within the cell and kills the cell, and it also has a so-called bystander effect. It will kill cells around it as well, and that's why it's so effective. And the first ADC approved in triple-negative breast cancer was SG, sacituzumab govitecan. And this was done by the ASCENT trial. You had very highly pretreated triple-negative patients with more than 2 chemotherapies. And then it was either the physician's choice, either eribulin, capecitabine, gemcitabine, or vinorelbine, or SG. And you see the results on the next slide. It was a huge difference between SG in this turquoise color in comparison to all the other single treatments. So SG was had quite an impact. At a late stage of pre-treated patients, you still have a substantial outcome improvement using this drug. And another drug which comes from the HER2 positive treatment situation is called trastuzumab deruxtecan. And with this kind of ADC, it was possible to also treat triple negative patients, because even if the expression of HER2 is only very low, like, I don't know, you have the results from your pathologies, HER2 plus, 1 plus, 2 plus, and 3 plus, or 2 plus and FISH positive or negative. Also in HER2 1 plus, this drug is very effective due to the payload, deruxtecan, which is introduced within the cell, and you see here an overall survival benefit in patients, also triple negative patients. So therefore, we have the addition of these drugs, sacituzumab govitecan, in the treatment of metastatic triple negative breast cancer. And I think that's a very interesting development. And there are many other ADCs in clinical development. So we will see quite a flood of drugs coming up, either as mono-drug treatment or even in combination with immune checkpoint inhibitors in the future. So I think that's my hot topics for the field of breast cancer and early and late breast cancer. And yes, I hope I can also invite you all someday to Hamburg, to our wonderful clinic and place to share all your clinical experiences with us here live one day.
Thank you so much, Christian, for this kind of overview. And I have one more question before I go to the question from our audience about the new study, Destiny Breast 6 study. I heard that this was kind of very interesting and maybe unexpected results on the last conference. It was in ASCO, first presented in Chicago this year. Can you say a few words about this study? What is this interesting, and maybe it will change some strategy in case of HER2 positive breast cancer?
Yeah. So in this DESTINY-06 trial, there was a group of patients who were HER2 negative, totally negative, like zero, ultra low, they called it. And even in those ultra low subgroup, we had a positive signal or a benefit from the introduction of trastuzumab deruxtecan, which means that you hardly need to test for HER2 expression. You can always use this drug, which is very good in any kind of clinical situation. And then we also ask ourselves, this drug will be the simple answer to all questions. Do we have to divide between triple negative and hormone receptor positive anymore if we have this drug available? And that's why we have a lot of discussions. Right now, the discussion is these drugs are very helpful for serious breast cancer situations. But in a metastatic situation, it's also about the quality of life. Until we have proven that we can totally remove the tumor, which isn't even possible with T-DXd, we should always try to use the drugs which are in a balance between anti-tumor therapy and good quality of life. And these ADCs have some kind of side effects, hematological side effects, GI side effects, and some fatal side effects in very rare cases as well. It's a very rare sort of pneumonitis, which can kill the patient once it's not detected early enough. It's a lung disease. And so in our clinic, we have the rule whenever we use the drug, we will educate the patient. Whenever you have any kind of symptom with your breathing, come to our clinic immediately, that we can stop the drug and take action and make some kind of diagnostics to prevent this serious situation of pneumonitis, which can be deadly. So, but it's also good to have this potent drug in the bank hand. So you have treated the patients very long, with everything you know, then you still have T-DXd to use in a way which might still help, although it's been pre-treated a long time before.
Yeah, thank you so much. So I see there's some colleagues answered already some questions in the chat. This is good, so we don't need to cover the question. But we have some question from our colleagues and patients. They put it after the registration. So let me read the question, and maybe you can short comment some of them. We have less 10 minutes, and this is, I think, enough time for these questions.
Okay.
So the first was in vitro fertilization, possible after 5 years of remission following combined treatment for stage 3A hormone-dependent breast cancer.
So
5 years after.
Yeah, after you finish your endocrine therapy, if you are free to have an IVF treatment, I think yes, you can do. There's also a trial where they checked for pregnancies if you have a break in your endocrine therapy. So, for example, you do endocrine therapy for 2.5 years, and then you stop it, have an IVF treatment, get your baby, and then start your endocrine therapy again. And then they looked for the baby take-home rate, which was good, and they looked for long-term outcome, and which this long-term outcome, although they had a break in the endocrine therapy, wasn't decreased in
Yeah.
it was normal. So that's what we talk with our patients as well. So if you have, like, for example, a 35-year-old woman or a 30-year-old woman who has breast cancer, I would say probably get some ovaries removed before we start the whole chemotherapy, for example. And if you have a partner, have them fertilized as well, because fertilized eggs are better storable than eggs by itself. And the baby take-home rate is higher. Then go for chemo, then go into endocrine therapy for 2.5 years, have a break, have your baby, and go back to endocrine therapy. This is possible. And once you've finished 5 years of endocrine therapy, I think this is done by then, unless you have an indication for an extended endocrine therapy. There's also something like that. For example, you can discuss extended endocrine therapy for patients with high nodal involvement, for example.
Yeah, okay. I think this good answered. The question is about the tamoxifen dosage. The standard dosage is 20 milligram daily for all women, regardless of the size. This is the question. Would reducing my dosage by 10 milligram affect my prognosis?
Good question. So the older trials for approval for tamoxifen were always done with 20 milligrams. And so therefore, this is the recommended dosage. And the question, does the weight of the body play a role? It does not, because if you have a very low weight or high weight, the dosage is so highly calculated that you have a safe level of this drug. Tamoxifen is a pro-drug, this drug in your system. But there have been trials, a single trial, not randomized, with a lower dosage of tamoxifen, 10 milligrams, and they still had a very good outcome with this. So in our clinic means this, if I have a woman who's taking tamoxifen and has really serious side effects and said, I want to stop the drug, I can't go on like this, I will have the opportunity to say, stop, before you don't take anything, we will try to reduce the dosage, and it's still better than taking nothing. So go for it and try it, but not in the first place, and regardless of the weight.
Great. I have some question. Maybe it's more for me, for breast like diagnostic radiologist. In our oncology center, all women over 50 to 70 years are mandated to have a mammography and ultrasound. Is this approach appropriate for all women in this age group? So we have in Germany a screening for all women between 50 and nowadays between 50 and 75, 2 years, but only with mammography. This is in a screening. So the ultrasound is not in this screening program. So only if you have some findings on the mammography, you will invited for some further examination, ultrasound, and some additional mammography, but not in the first step. So I think this screening program is like more than 20 years or 30 years it was developed, and we have some more data for a dense breast and for some risk patients. I think we will have in next 5 to 10 years another screening program more adapted for individual risks, but now we have only this mammography every 2 years from 50 to 75 in Germany. Okay, so we have a question. Is neoadjuvant endocrine therapy a viable option in Germany instead of neoadjuvant chemotherapy, what is your preference? I think you answered already. There was a DUB study, yeah, about this endocrine therapy or something.
Yeah, but I think in the ADAPT trial, the endocrine therapy is not a neoadjuvant
I see. Okay.
replacement of chemo. Uh, but I think certain indications for that. For example, just today, I had a very old woman. She had many other diseases, arthrosis. She's not walking very well. She has hypertension. She probably had a heart attack or whatever in some kind of earlier history. So there is no way, although the tumor biology calls after chemo, you can't treat her with chemo. In this kind of situations, and probably an operation might be dangerous as well. So in this kind of situations, we often use endocrine therapy by itself to have a stabilization of the disease and have regular checkups if the disease is in control. But I think it's not a replacement for neoadjuvant chemotherapy because you use neoadjuvant chemo in breast cancers, which are highly proliferative. And in this kind of cancer, endocrine therapy is not very effective. It's very good for slowly growing cancers, so therefore it can't be replaced by each other, I think.
Thank you. I will have some question from the colleague, the doctor. For new treatments like CDK4/6 inhibitors and oral SERDs in estrogen positive, HER2 positive breast cancer, should we reconsider treatment approaches to ensure fairness and efficacy?
I didn't get it all. Do we have it in written here somewhere?
Yeah. I can send it in our chat maybe, but so now it's in our chat for new treatments like, okay, sorry, this is in, I just put it in all, so you will see it. Yeah.
So it's below. Okay, for new treatments like CDK and oral SERDs in cancer, should we reconsider treatment approaches to ensure fairness? I don't get the question. What do you mean by ensure fairness and efficacy? I mean the CDK4/6 inhibitors are helpful to reduce the rate of recurrence after you've done your surgery or even after you've done neoadjuvant chemotherapy. Because for example, in the NATALEE trial, hardly all or most patients had chemo before that. So they had chemo, reduction of risk with chemo, and on top they had endocrine therapy and the CDK4/6 inhibitors. And therefore, I think it's an addition, but I'm not sure if I got the question.
Yeah, okay, but
by to ensure fairness and efficacy. I mean, fairness in approval or fairness in availability of the drugs. The SERDs are coming up right now, and the first SERD introduced here is elacestrant in a metastatic situation is doing a good job, but not for all patients. We have a very big drop down in if you see the curves, like 30% of the patients doesn't work at all, and we don't know why, and they will progress on elacestrant very quickly.
Thank you. We have last two questions from our audience. So I will put it in the chat and I will read it. As a 39-year-old in remission after hormone-dependent HER positive stage 1 breast cancer, what should I do to safely stop tamoxifen and trenantone if I want to conceive?
Okay, I think it's the same situation as I said. At least this endocrine therapy period should be 2.5 years long. And then you could make a break for conceiving. and you should start after conceiving, and the break shouldn't be longer than 1 or 1.5 years. And if you can't reach a pregnancy during this time, don't try too long to make this break too long. So that's I think you can do. And don't wait for a spontaneous pregnancy. Probably go to an IVF doctor, a fertility center, who can effectively guide you to the pregnancy, more than if you're waiting for a normal menstruation coming up after chemo and Trinanton.
Yeah, we have some comment for previous question. Probably question is CDK4/6 new oral SERT are not approved for HER2 positive disease, not assessed in large trials.
That's true. It's not approved for HER2 positive disease at all. So it's only for hormone receptor positive, not HER2.
Yeah. So when
I made a mistake talking and said HER2 positive. It's only hormone receptor positive.
Yeah. And I have a last question. I tip it here. With an Oncotype D.
But why, if he's asking? Because you don't need. Are you still on? I think you're frozen. Everybody's frozen. Sergey, can you hear me?
I think Sergey needs some few minutes to reconnect to us.
Yeah, now he's back on.
Okay.
But yeah, so the colleague is asking why the CDK4/6 inhibitors are not approved for HER2 positive breast cancer. I think we have other very potent drug in HER2 positive breast cancer. In HER2 positive breast cancer, the tumor biology is driven by the HER2 expression. And that's why we don't need CDK4/6 inhibitors.
Yeah. Okay, so we have some more questions, but our time is unfortunately like 1 hour is gone. Yeah.
Not enough for
we can discuss. Not enough, yeah. But I want to say thank you so much, Christian, for your time, your insights, your comments and answers, and sharing the knowledge. And I also thank you everyone who joined us today, the doctors and patients. Yeah, thank you everyone. Thank you, Xenia, for technical support as well. And yeah, finally, I want to say that we will save the recording of this webinar for sure, and we'll share it in our channels. Yeah, thank you once again, and I would say see you next time.
Thank you for having me.
Thank you, Christian. Bye-bye.